everybody. Welcome to the Genius Project. I'm Susan Clinton, one of your co-hosts, along with my other co-host, Carolyn Van Dicken. And we are here today with guest Corey Blinkenstaff. This is part 3 of our project called Serenity Against the Pushback, the Challenge of Change. And we also have a couple of other physios here with us. Jill Mueller is with us today. And Tanya, introduce yourself. I don't know your last name. I'm sorry.
Oh, my name is Tanya Blubeck. I work as a physio in Toronto, Ontario. I trained with Carolyn 22 years ago in public health.
Yes, we did.
I work mostly in breast cancer now and geriatrics 1 day a week.
Fantastic. Welcome. Thanks for joining us. I believe we have one more person who has just chimed in. Nicola, are you with us? She may come back in. I think she's trying to.
There she is. Hi, Nicola.
Okay.
Beautiful. So really anybody can chime in at any time with a question. And we really want this to be an interactive discussion. And so please feel free, if you have a question for Corey or for any one of us, to go ahead and start.
And you can also use the chat box if you hover your cursor down on the bottom or on the top, the toolbar will pop up and you'll see a thing that says chat. And if you're a little shy about talking on camera, just drop your question into chat too. Okay.
Beautiful. So we were chatting over the last 2 months with Corey and with just Susan and I about some of the challenges around change for physiotherapists and for our other colleagues who treat pain around moving into more of a consistent biopsychosocial framework and why that's so challenging for us as professionals to do that. And one of the reasons clearly is that there's still a very biomedical drive to our training. I mean, I think when we graduate here in Canada with our master's degrees in physiotherapy and in the United States with your doctorate degrees, the training is still predominantly biomedical. And so, to make that shift or change can be a real challenge. So one of the things that Susan and I talked about is, we all treat differently, and that is a good thing. I think that is a strength. One of the things that we have talked about is that there are probably some non-negotiables if we really want to stay consistent with the research and the literature around treating pain from an evidence-based perspective. And one is that we should all be using a biopsychosocial framework with all of our patients. The second is that we really need to look at our language carefully when we talk to patients, that we need to create positive expectations with our patients. The third is that pain education should form the basis of our treatment and should be tailored to the individual. So not the same spiel for every person, but the same concepts being reinforced, that pain is an output of the brain. And the fourth piece is that self-efficacy and building self-efficacy should be the overarching goal of all of our treatment paradigms and treatment things, what's the word I'm looking for? Treatment tools that we use in the clinic. So those are sort of the 4 pieces. I'd love for everyone to kind of chip in and just talk about whether or not we're missing a non-negotiable. So within those non-negotiables, are there other things that we should all really try and agree on? And do we all agree on those non-negotiables? Are there things within that we think, oh, no, we don't all have to treat from that perspective? So does anybody have any thoughts on that?
Well, I'll jump in. I think all of those things are great items. I wouldn't argue necessarily with any of them. I think one thing, as far as the difficulty of going, between models, between biomedical models and biopsychosocial models, is, or can be at least a little bit of a missing piece. Maybe is a focus coming from the patient through the model instead of from the model onto the patient. So when we look at the biomedical model, like its success kind of has breeded its popularity, right? So like the things that it was developed for, treating diseases, it's wildly successful with. I mean, it is one of the great successes of medicine and of science.
Right.
And so The problem comes when that same model is applied to things outside of diseases. I really like Norton Hadler saying that a disease is something that an organ has and an illness is something that a person has. When we try to cast that disease model onto the person, something the person has, it doesn't work out so well. So the biopsychosocial framework really broadens the perspective to try to look at more categories of things, more things that might encompass what a person is going through. But especially when you're already coming from that biomedical perspective, when you're looking for problem A or issue A creates problem B, the biopsychosocial model can just be a bigger mousetrap, right? I mean, it can just be like a recipe of, okay, it's not only this biological problem, but also you sprinkle in depression and you sprinkle in anxiety and you sprinkle in that they live alone, and that recipe somehow ends up in pain. Versus, so that's what I'm talking about as far as looking through the model and casting those findings onto the person, right? It's almost like a checklist. Okay, depression and anxiety, these things are kind of in the, one realm of the biopsychosocial model, and this person has those things. So check, those things are in the recipe. Versus when you look at it from the other direction, this person can't get to the car to go be with their friends and do the things that they enjoy because their knee pain or whatever is keeping them from doing that. And what are some potential targets of intervention that might help that person be able to accomplish those things? One of those things might be more social inclusion, having people come into their house, and that might help with their things like their depression and their anxiety and their sense of loneliness. So I really feel like that is one of the difficulties, especially coming from the biomedical model, where we kind of are trained to look at this A causes B type of thing, where we just kind of transfer that thinking into a broader way of thinking. So I think if we flip that around, instead of looking through the model at the person and looking at the the mistake we're making is looking at the person through the model, when instead we could be looking at the model through the person. I think that is something that would help.
Right.
At least that's my current take on it.
Right. I think that's a really interesting. I've not heard it put that way. I do like Norton Hadler's work as well, when we really look at the difference between kind of health and wellness and how we define that. So really it's about focusing on the individual and not trying to make the model fit the individual, right? Yeah.
Right.
Yeah. And I have a comment on that as well. Just the trouble that I think a lot of, myself included, is that people come into physiotherapy expecting physical therapy, and I just took a motivational interviewing course, so I think that is going to be really helpful. But getting them to see that there is more to them than their expectation of what they're going to get from us. And that part is the part that I see you saying, like seeing the person and almost where the person is at this point. And I've found that sometimes I have to kind of wait a few treatments until they trust me, and then start implementing a little bit of expanding from what their expectations are. I don't know if that goes along with it.
I think sometimes the challenge can be that we sometimes start in that biomedical model, though, Jill, because that's what we think our patients are expecting, right? And then we try and switch into more of a broad-based model, and that's when we sometimes get into some trouble with our patients then thinking, well, now, hold on a sec, you told me it was more about kind of the tissue piece and you're working on my tissues, and now you're talking about sort of broader-based issues, and now I'm hearing you say that you think it's in my head, right? Like that's sort of the transition that can.
So then it looks as confusing almost, or could.
I think our language has to be consistent from the beginning. I think that we can talk about. I think the other thing we forget about in the biopsychosocial model, though, is that the bio piece is as important, right? And it's not just about the psychosocial sort of drivers that may or may not be there. But if we treat the tissues or address the tissues, that it's within a less threatening framework, around, often I think we still talk about dysfunction, right? These tissues are dysfunctional. I always like Sandy Hilton's interpretation of that, where she says, you know, 3 things can happen in persistent pain. The tissues can be tight, the tissues can be weak, they can be sensitized, right? And so, but we really have been trained to think about the mechanics of the tissues and what's wrong with them. And that fits in the biomedical model.
Mm-hmm.
Right, and I like what Corey was talking about when he's talking about the person and looking at the person first, rather than the knee pain first. We'll just use, he brought it up first, so we'll just use knee pain. And the persons will sit there and talk about their knee pain and how it hurt and how they hurt their knee and all of their things. And I think where we need to go and spend more time, or the challenge is what is your knee pain really keeping you from doing? And then tell me more about that, tell me more about that, so that we're actually giving them the space to really talk about that. When you say you can't get in the car and go do things, what things are you not doing? What would your life look like without this? How, you know, and so you're broadening that perspective around the knee pain from the very beginning in a way that can give, and they may not have all the answers right then about what it would be or what they've let go of, but they will by the next time if you give them the space to kind of begin to say, oh, they really care about what I'm afraid of. Because it may not be the knee pain at all that they're afraid of. It may be that they're afraid of ending up not, you know, in a, you know, I mean, people go to worst case scenario, right? Ending up in a wheelchair in a nursing home, never being able to walk again eventually, that this is the beginning of the cascade of terrible events and things like that. So, you know, being able to kind of start to build that alliance in the very beginning can really set the tone for, we're going to look at a lot of different things with this person because they're asking me questions in which nobody's ever asked me. And I'm certain, Jill, that you found that too, even before your motivational interviewing class, you know, that's kind of the piece of where we go as physios. I think Nicole has her hand raised. I'm going to unmute you, Nicola. Hello, can you hear us?
Yeah, I can hear you.
Good, we can hear you too. Welcome.
Hi. I've never used Zoom before, so apologies for my tardiness.
You're doing good.
In response to what Jill was saying, one of the things I find really, for me, has changed even the way people, their expectations before they come in, is the paperwork they fill before they come in. So, like, you know, my first question is, what are your goals by seeing me? Not what's your pain, what's your problem? And then having the questionnaires and then spending time, whether it be 5 minutes, 10 minutes, even if all those questionnaire scores are low, I explain why I do the questionnaires and what that means for the way how I work and the way I perceive how physiotherapy works for me versus what they've had. And a lot of my clients, unfortunately, have had physio before, so they do come in with the expectation, you know. And I actually had someone yesterday, oh, you don't have any machines here. I said, no. And she went, that's good, because they're rubbish. You know, it's just trying to kind of change the way people perceive what we're going to do. And I think if you can do that even before they come in to see you, when I send out the paperwork, I say, this is quite lengthy, but it gives me a real picture of what's going on in your life, not what your problem is. So, yeah. I find that gets a lot of investment from my patients. So by the time they come to me, they already know that the way I'm going to look at them is going to be different from how they've maybe perceived that to be.
Nicola, I think that's really, you know, been my observation as well. And I guess one of my questions, maybe to Corey, but to everyone to kind of think about, and to anybody who's listening to this podcast, is why is it so challenging for us as physiotherapists to integrate some of the psychosocial questionnaires? We're really afraid to do it. You know, when I teach that piece in the pain course that I teach, that's the piece I get the biggest pushback from is, yeah, but patients don't want to fill out that much paperwork. It's too much paperwork, right? But it sets the tone, as Nicholas just suggested, in setting the expectation of, oh, this person's really wants to know everything kind of about my person, my being, my goals, and is interested in me as a person, not just me as a knee, right?
Yeah.
Any thoughts on why it's been so challenging for us to integrate those questionnaires?
Well, I can talk about why it's challenging for me.
Yeah.
So I think, you know, for one, first, the positives that I consider about those things. I mean, for one, obviously, I always talk about three things: set a baseline, set up experiments, practice. And, those questionnaires can be very useful in determining where somebody's at. I would say part of the challenge that I have is that, I really want the person to tell me their story in their own terms. I want to know, what they're thinking and their version of what's happening. And one thing I don't like about questionnaires is that it kind of puts the narrative in a preconceived path, right? Like you're answering questions in these terms that have already been spelled out. So for that reason, the one that I'm most likely to use most often is the patient-specific functional scale, because it's basically a blank. They can fill in their own, what's important to me, how much is it involved. You can really kind of stay on the path of letting them tell their story. I think that's one of the challenges, and then also just there's so many, knowing kind of what to do with that information sometimes can be a challenge. Like catastrophizing as an example. I mean, we know that a lot of people in persistent pain are, high scores on different catastrophizing scales. But then different populations, you find it's more or less important about how much that changes. And if changing that matters, some it seems to be important, some it doesn't. Sometimes when catastrophizing is high, it looks like those are the people that we're probably not going to see changes with. Other times it's not. So I think there's a little bit of a struggle of just kind of, what to do with the information from all of these. But that's my own.
Yeah, your own take. Yeah, it's interesting. I mean, I don't use the patient-specific functional scale. I do, I probably use 6 or 7 right off the bat, as Nicola sort of talked about as well. But then I just sit back. So they fill it out, before they come in, and I sit back and I just say, can you tell me your story? Tell me your story. And I don't actually go over the paperwork that they filled out for probably at least a half an hour, right? Mm-hmm. Like, just, I want to hear your story. And then, okay, so let's see what you actually sort of filled out here and how that fits into, because now I have their story. Does what they kind of reported fit in with kind of the story that they told? And it now gives you another opportunity to kind of reinforce what they've already said, or because this is sort of a more objective measure, right? I find it interesting that as physios, we're very comfortable measuring physical function like range of motion and strength, but we are more hesitant to measure the psychosocial distress sort of components, right? And I also think that if we start to really look at the literature, I think we can get some clues. So for catastrophization, for example, Corey, I might definitely, when someone's got high catastrophization scores, so greater than 30 on the PCS, for example, that person really needs to reconceptualize pain, right? So pain education is going to be kind of a star show in our treatment program. Where someone has high depression, for example, I might decide along with them that, exercise may be an important component, whether it's cardiovascular exercise or maybe yoga, to help address the depression component. But like you said at the beginning, if we don't measure it to start with, then we can't then assess whether or not our treatment interventions are effective for that component of their presentation, right? Mm-hmm. So it's interesting. I do think this is a real struggle for us, and I am a big proponent of using them consistently so that we have objective measures to kind of reinforce. And I find it really interesting because my patients, when, because I try and do them again about every 6 or 8 weeks, especially the ones we're targeting, they really are keen on kind of knowing sort of how things are changing objectively as well. They feel better, but oh, look at that. My depression score has, gone from the severe category to the moderate category. Oh, I'm feeling really good about that, right? So I don't know. It's interesting. I think it is a challenge for us to kind of incorporate those.
So some of the things in the comments that I hear out there, a lot of times with people with where they feel comfortable in their practice, and when we get into these questions and we start asking them about, the psychosocial pieces of their life and hearing their story, and many of the PTs that I run into will say, if somebody's depressed, I don't think they belong in my clinic. Mm. They don't know what to do with that. And I like your practical advice is they may need to be referred, right? They may need that piece. But that doesn't mean there isn't something as a PT that we can do, because depression will respond to movement. Mm-hmm. And it may be, even kind of just making decisions like, okay, what's your favorite music? Can you turn it on and see if they begin to move to it? Maybe that could become the trigger to help them pull through, because they still need to be treated even if they are depressed. And I think people kind of look at that as like a red flag. Depression, oh, this is bad. We shouldn't be doing this. That's what I hear all the time.
Right.
Are we supposed to be doing this? This is not what we're supposed to be doing. The other thing is I love what you said about the pain catastrophization scale, or anytime you think somebody is catastrophizing, whether you use a scale or not, is that's, what are the go-to things that we can do to help people begin to change their story? And is the catastrophization because they're afraid? Or is it, heightened because of the contextual piece of how it happened around there? Like there's lawyers and all kinds of other things involved. But, the idea is that pain education can be one of the foundations for being able to help them begin to understand that, oh, this isn't because my tissue keeps telling me that it's hurt and I'm damaging it further and I'm so afraid to move because of that, or it's going to get worse, right, with the catastrophization part. But instead, like, this may not be what I thought it was. I wonder if I do this differently, that maybe I'll start to see the changes I want to see, because what doing the other way wasn't working, and maybe this was why. I kind of offer that out there as that, because we have to have things to be able to do. And I think that's where they stumble, is they may give the questionnaires, or they may say, I don't have time for that. But if they do give the questionnaires, what do they do with the answers to that?
It's interesting. There was just a study published, and I want to say it was Traeger in 2018, that looked at the progression of acute low back pain to chronic low back pain, and whether or not pain education in acute low back pain actually stopped that progression. And they found actually it didn't, except for those who had high catastrophization scores. If you had a high catastrophization score and you did pain education, that would intervene with the progression from acute pain to persistent pain. So I don't think we have any studies yet that show, when you do pain education, catastrophization decreases. But I think we have some evidence-informed practice that will start to allow us to match how we address some of these psychosocial concepts with some targeted treatment that are within our scope of practice. Corey, what do you think?
Yeah, I was going to try to kind of jump around and tie a couple things together from the earlier comment too, about, the expectations that people come in with. So for one, we actually, Sandy and I's podcast, we just got done with an interview with Adrian Traeger and James McCauley about that paper.
Oh, did you? Okay.
Coming out soon. So pretty excited about it. So yeah, they did not see change.
Mm-hmm.
In fact, one thing that they said was that it didn't even outperform natural course history. Right. Which was pretty interesting. So to kind of jump around here, I think for one of the big things as far as how I've changed over time and how I practice that's been important, I feel like it's important for me, is, when people come in with their expectations, okay, this is what physical therapy is probably going to be, this is probably how it's going to go. When I made that jump from kind of approaching it as I'm the person who's going to meet those expectations and create the fix, to more what I call that contextual architect, where my role is really to kind of set up the environment that a person can kind of go through the process on their own and make their own changes. That was really helpful, because then that also kind of led into if somebody comes in and says, my knee is trash, it's never going to get better, and I just jump right in and say, no, it's not trash. This is what this, and this says. There's no reason to think you can't get better. Even if the person kind of can conceptualize that, what the research says is that it's really probably not going to change their behavior in the way that they're going to approach things. But what might make a change is if that person can show themselves that way of thinking was false. All right. So what I'm always looking for, and this was already mentioned as well, Susan, I think you said this, is that when a person kind of has that time when they say, that's weird, I didn't expect that. Excuse me. That's what I feel is the best time to jump in with education. Excuse me. When a person is no longer looking for a way to confirm what they already think, but they're looking for a way to explain why things did not turn out how they thought they would, like that is when I think education can be really powerful. And in those terms, it kind of makes sense. You're not necessarily trying to change a person's pain. You're trying to help them reconceptualize why things didn't turn out how they thought they did. So they're updating what their expectation is. So that's where I think, really we have a large role or a valuable role to play is kind of helping a person update their expectations and showing them, our role is to maybe know, like, okay, they might have some misconceptions here, but I'm not just going to go tell them that they're wrong, because that's not going to go out right. I'm going to help them kind of through a process where they can figure that out themselves, and then I can help them make sense of it as they go through it. So yeah, I think that was everything I was going to say.
Okay. It's interesting as you say it that way. I find that really fascinating, because you're kind of saying the same thing from a physical experiential perspective that Jill was saying from a motivational interviewing perspective around kind of using words and questions to get people to understand their own sort of reason why they should change. And so that can be sort of a dialogue, but it also can be an experiential sort of thing that happens in the clinic where they start to kind of put those pieces together so that they are the reason that change is being made, really,
Yeah.
right? Be the reason.
Absolutely. I mean, one of the drills, one of the little kind of exercises we go through in my workshops is we go through that motivational interviewing concept of open-ended questions, but then we say, okay, so that makes sense when you're talking to somebody. How do you ask an open-ended question about asking somebody to move? Are you being consistent with the way you're approaching these things? Are you being open-ended with your subjective questions, but then you're saying, okay, move this way. Show me this is the right way to do it. Show me you're doing this, right? Is there a way that you can kind of be consistent with that concept between the multiple ways we're interacting with people? Because it's all interaction, right? I feel like all of our communication, all of our interaction should be consistent. So
yeah.
Is that where maybe mindfulness comes in with movement, where we can just get them to pay attention to, okay, so what happens if your breathing changes, if you exhale on the bend down, if you let your abdomen relax, and what does that feel like? And that's where that experiential movement and bringing mindfulness into giving them ideas of how to play with that movement a little bit, because then they might take that outside of the clinic and say, oh yeah, these are the concepts that we went over. Maybe I could try that when I'm going for a walk. What happens if I let my bum relax a little and I don't squeeze it as tight? And I don't know.
Yeah, I use the words "I'm curious" a lot.
I love that.
It's a very subtle shift, but instead of saying like, okay, now next time you do this, breathe differently, to saying, I'm curious what this would go like if you did this a little bit differently. Do you think you might want to try that? I mean, it's a subtle little shift, and it might seem silly, but then now the power has stayed with the patient, right? That you're more inviting them to try something versus telling them do this.
I like that.
And then if it goes well, then you can kind of say, well, I'm curious how that might go if you apply this to your walk this afternoon. Maybe you might try that and let me know how it goes. It's subtle, but it's that it's that self-efficacy thing where you're letting them kind of still be the one in charge.
And you're not giving them rules, right? Here's the rules around how you need to move. And that, again, is a big shift away from how we've been trained, I would say, right?
Exactly. So Tanya has a question. How do you find that pause as a therapist? For example, before jumping in and finding solution as a therapist, you pause long enough to help the client find the solutions. I think she's referring to how do you get comfortable enough and know how much time to give them and space hold the questions that you've asked them. Because as PTs, we do tend to like, okay, I know what the answer is, and to just sit back and not say anything and really allow them to process.
Yeah, I think for me, it varies from person to person. I mean, some people are much more, the dialogue is a much more important way for them to learn. So they're going to be very, more apt to ask the question. For other people, it's just kind of you march from one kind of movement into the next. I'd say I'm much more, I'm much less concrete with the flow of my examinations. Our subjective kind of blends right in with movement, and they just kind of continue right alongside of each other, and we're experimenting right along that. Like, I'm curious what it might look like. Could you show me what you're talking about? What does it look like if you raise your hand? Oh, okay. And they say, yeah, that's exactly what I'm talking about. When I put this thing on the shelf, and I'm going to say, oh, okay, well, I'm curious how that might go if you breathe a little different, or you did, this or that from this angle. You want to try that? And so it's kind of this continual thing, and they might make that change. Let's since I shifted over the shoulder, let's say, then it goes a little bit better. And, while they're up there, I might say, oh, cool. So what does that mean to you? Is that surprise that you might, that went how it did? You might ask some of those types of questions. Did that turn out how you thought it would? What do you, is that what you were talking about? Again, just kind of inviting them to reflect on what that is and what it means for their particular problem. And then, sometimes it's just a matter of, them showing you the next movement, you just kind of keep experimenting. So I think it really depends on the type of, the involvement of the patient you've got to. In some cases, to Carolyn's point, it's going to be very important that you set your baselines much more directly, because what you don't want to have happen is the person, to set up their own experiment and then it goes well, and to them have a way to say like, oh yeah, but that's not really what I was talking about, right? Like you want them to kind of be able to commit to, this is how I expected this was going to go. And so that they can clearly see when it didn't. We don't want a lot of moving of the goalpost happen. So, a long answer to your question. I think it really kind of depends on the person, but sometimes you just might jump in there and say, what did you think about that? Or is that surprise? I don't know if is that getting to what you were after? Yeah. Okay.
Yeah. Sounds good. Okay. All right. Why don't we, I guess my last question maybe for Corey and for the group is to just think a little bit about, we talked in our first podcast on this particular project about this concept of othering, right? And sort of this disconnect sometimes between us and our patients, but also I think between ourselves professionally, how we can become so siloed. I take a biopsychosocial approach, I take a biomedical approach, I'm a public health therapist, I'm a FCAMP therapist. How is it that we can really become more cohesive, I think, as a profession moving forward, to have some consistent principles maybe that we can all agree on? Is that a pipe dream? Is that something that, is a realistic path for the future? Because I see a lot of division, right? In the Canadian Physiotherapy Association, there's all these divisions. There's the pain science division, there's the orthopedic division, there's the women's health division. But we all treat people in pain. And, I don't know, I would like to see a little bit more consistency, I guess, in that. But any other thoughts on that?
In the States, I would say one of the biggest challenges that we've got in that regards is just the payment system that we work within, honestly. It's we're not necessarily paid for doing good work. We're paid for doing more work for the most part, and you could argue that point, say good work is going to beget more work and all that. But, really the way you charge for a visit and how you work with folks, it's like the more procedures and things that you do, and so on and so forth. And so I really feel like that drives a whole lot of this, really. It's just, it's the incentives are a little bit
right.
Screwed up down here. I think that's honestly one of the big things. And of course, there is not an easy answer to that. It's going to continue to be an issue. So, as far as what can we do, we're not policymakers and we don't make those decisions directly. So I think, honestly, this type of thing I think is important. I think having more conversations, in the time that I've been involved in talking about these things over time, honestly, I feel like things have improved a lot. I mean, like it's no longer just like this, fringe set of concepts that we're talking about. People are familiar with it. I think the struggle now is how do we plug in these things that we have accepted and make them work in a practical setting. I feel like that's kind of where the shift has gone lately. And then, just like anything else, it's just got to reach a tipping point to where it's, more and more people are doing it. But I think the more conversations like this, the more people are talking about it, the less it's, this kind of thing that just a couple therapists are doing and more kind of like that. That's the way that's best practice.
Right.
Could do it. And then we need models that can be successful to have a practice in, like it has to be a successful way to run a practice. That's the challenge.
Yeah. Cool. Anybody else have any thoughts or comments on that?
So I think the other thing, I agree with Corey on the payment system, but I think the other thing is that we spend a lot of time being busy without really doing the things that we need to be focusing on. And part of that is discomfort. And I truly think the more that people become more comfortable with the language, more comfortable with the thought processes, and more comfortable with the idea that the therapeutic alliance is more about the patient on their journey and not our directed journey for them, I think we're going to continue to see those shifts. And even in practices that are busy, and I know that there are people who are required to see high numbers of patients a day, there are still patients within that time frame that you can still approach in the same way. You can still give them a choice out of the things that we need to work on that we've talked about. What would you like to prioritize? Give it to them. Anytime we can give it back to them and get them to notice the changes. And like Corey said, don't allow them to keep pushing those goalposts further and further away, but stay in the moment and let's figure this one out right now, because you'll be able to apply this when you leave the clinic, rather than trying to just rush them through maybe a shift of exercises that they already know how to do and they can do on their own. But how can you do them in a way that is changing your response system? How can you do it in a way that actually fits with your lifestyle? How can you do them in a way that is meaningful for you? Like, what would be meaningful for you about this exercise? when in your life are you going to do, when do you bend over? When do you do it? Can you think about, like Corey, I'm curious, what if you tried to do it differently? Like some of the ways you were doing today here. What would happen if you gave that a go? You know, and then they come back and you still can spend a short amount of time with them, but still accomplish so much more. And I agree with him that we just have to keep having these conversations because we all learn so much and change so much every time.
So Tanya writes in the chat room that she takes students from the university and shares with other therapists in the pain program and sort of traditional outpatient ortho, and have them just integrate a case, right? So again, trying to always, I think that is brilliant. We need to work within the settings that we work in to encourage all of us to use a more consistent framework, kind of have this collective kind of responsibility around treating people in pain in a more evidence-based way, right? And Tanya also then says we're putting together a narrative medicine group across professions so that we can become more comfortable with the language and learn from each other, so we can learn to listen and respond to someone's story. And so I think, again, we have so much to learn from other colleagues that maybe do that narrative piece better than we do. That hasn't been a big part of our training. I think about our occupational therapy colleagues, right? Who the psychosocial piece is a much stronger part of their training. Our social work colleagues, our psychologist colleagues. And it's interesting, the majority of them have supervised practice where they have kind of someone, a mentor that they sit down with once a month and go over some difficult cases. And a lot of that is going to be around case management and the psychosocial pieces. We don't do that as physios as well. And maybe that's a direction that we need to think about for our profession to really grow in this more challenging area. So thanks for sharing that, Tanya. Yes. Nicola, any other thoughts or comments before we sign off? Not to put any pressure on you, but...
There we go. The supervisory role, so I trained and was educated in Scotland, and we always have supervisory physiotherapists among us. So even if you're supervising a department, there's still somebody above you. And we had the role of extended scope practitioners as our resources. So these were people who'd been practicing in that area for a lot longer, and they were our resources. And even if they didn't work within our clinical setting, we did monthly in services. And I think that's certainly something I noticed being a solo practitioner in my own clinic. So little there's no willingness for collaboration, and I don't know if that's the area I'm in, if it's because I do pelvic floor and people maybe don't think I know enough about ortho to collaborate, but I think that's something, I try and pop on every live podcasts and do online courses and go on live courses. But I was really lucky to spend time with you, Carolyn, and I know Jill does that as well for people. But I think that's something we're missing as a whole in the profession, that there's less people willing to mentor outside of the student setting. And I think if we don't start doing more of that, we're not going to see the progress that we should see in terms of pain management and the biopsychosocial model. That's just, yeah.
Thank you.
And Carolyn, we've talked about this as well. This needs to be taught in university. I mean, it's kind of ridiculous that we're having to learn this outside. It's getting a bit better, but it is slow to change. And that's, we would like, I don't know, don't get me started.
But it is a collective responsibility that we all have to really change around us and all the spheres of influence that we have, because we do. So, if all of us can commit to that, as Corey says, there's been a great change in the last 10 years. I would agree. But it is, it's interesting. I was just listening to the Pelvic Health podcast this morning, and Laurie Fournier actually put Peter O'Sullivan's podcast that he had done 2 years ago back on for review. And it was just interesting to listen to his comments. And her comment was, this is now 2 years old, and why are we still struggling so much to make these changes, right? Why is this so slow? And so I guess that's the challenge to everyone out there, is to say, how do we really embrace a biopsychosocial perspective? And how do we really embrace, as Corey said, the patient's perspective on that, not our perspective, right? We really need to give the power back to our patients. All right, well, let's wrap up. Thank you so much, Corey. I want to just say thank you again for joining us for the second time, actually third. We had to cancel one in between because it just didn't work out from a timing perspective. So thank you so much, Corey, for joining us and for sharing your knowledge and clinical experience of making this shift from a biomedical model to a biopsychosocial model. Thank you, Jill and Tanya and Nicola, for joining us as guests. We really appreciate your comments and thoughts. And join us again next month as we start a brand new project.
Thank you.
Thank you.
Thanks.